I want to welcome you to the fourth and final workshop of this year's Lessons from the Field series focused on autism, final workshop for this academic year. We're glad you're all here. My name is Joel Hetler. I'm the director for the Center for Excellence in Children's Mental Health. We are housed within the Center for Children, Youth, and Families at the University of Minnesota. Pleased to have such a good turnout, both locally and with our host sites all around the state. And I just wanted to say a particular hi to some of the host site folks. We were at the MACMA Children's Mental Health Conference a couple weeks ago, and you came up and said hello to us. I just want to return the favor. So hello to Clay County and Bemidji, and please, if you do run into us at any of the statewide meetings, come up and say hi. We really appreciate the feedback and the chance to get to put faces. This camera that I'm looking at is a little impersonal. So I want to thank our co-sponsors who have been listed on the slides here. This series wouldn't be possible without their help. And so just a couple of housekeeping things before we get going. All of you should have folders, and in your folders you should have a schedule, bios for each of the presenters for today, PowerPoint handouts for the presenters, and a list of additional resources. As far as evaluation forms, in the metro area, please, that's you folks here in the audience today, please be sure to fill out and return the evaluation form before you leave today. We really do want and value your feedback. And for Greater Minnesota sites, please fill out the evaluation online at the web link that's provided on your schedule. And really, we do look at what you tell us. Certificates of attendance will be available as you leave today. One change in our schedule for today, a little different than how we've done things in the past, will be ending at noon, and rather having a separate question and answer period at noon, we're going to roll that into our panel discussion, which will be from 11:15 to noon. So questions from host sites can be mailed to us at cmhdata, cmhdata at umn.edu, and we'll be sure to include your questions in the panel discussion. And of course, host sites can still choose to hold your own local discussions from noon to 12:30. A couple of other housekeeping announcements. Host site coordinators, please be sure that your sites are on mute at all times. And for the people who are here in Kaufman, the restrooms are out and to the right as you leave the auditorium. And please be sure that you all have put your cell phones on mute. I guess I better make sure I do that too. But, I would like to introduce Dr. Larry Rosen. Larry's a board-certified pediatrician committed to family-centered, holistic child health care. He practices primary care at the Whole Child Center in Oradell, New Jersey, and he consults with the Joseph M. Sanzari Children's Hospital of Hackensack University Medical Center. He's the chief of Pediatric Integrative Medicine and a medical advisor to the Deidre Imus Environmental Center. He's nationally recognized expert in pediatric integrative medicine, and is the vice chair of the American Academy of Pediatrics section on complementary and integrative medicine. I had a few minutes to talk with Dr. Rosen as I brought him over here this morning, and I think that we're in for a very interesting and enlightening presentation today. So please welcome Dr. Rosen.
I'd like to thank the Center for Excellence in Children's Mental Health for inviting me to come here and it's so nice to see everybody here early this morning. The timing was really fortuitous because I was going to be in Minnesota anyway. There's a international research meeting that comes every 3 years in research in complementary and alternative medicine. It happens to be in Minneapolis this week. And we have some really exciting meetings around children's health and integrative medicine, representation from many different countries. So it's been a really invigorating time, and this is a really beautiful bookend and way to finish up the trip. Everyone's been really friendly and welcoming, so thank you. We're here today, I know, as part of your Lessons from the Field series, talking about autism, and I think that there really is, in practice, in research, in public health for children, probably no area more covered, more talked about, more controversial than autism today. And I think that speaks to how much we don't know, how much we need to know. And then to take it a step further, we're going to talk today about complementary and alternative therapies to add even a little more controversy to the issue. And I'm going to present half of the information is really about a paradigm. The other half is really about the nuts and bolts. And so, for those of you who can't read this, it says, I'm afraid you've had a paradigm shift. That's something in medicine that is happening more and more. And I think that when we look at what's happening in children's health today, in the complex chronic illnesses that are really the focus of what we do in our offices, more so than acute health, we do need to think about a shift in our system away from primarily disease acute treatment to prevention, wellness, and managing these complex conditions. This is a slide from the Centers for Disease Control and Prevention, endorsed by the American Academy of Pediatrics and other groups from 2004. This is 5 years ago. It's called the Autism Alarm. The purpose of this slide was to raise awareness that in many communities around the country and around the world, we were seeing a rising number of children diagnosed with autism spectrum disorders. The whole point of this campaign, which was endorsed by other parent groups as well, Autism Speaks, was to say, hey, we need to pay attention to what's going on. Let's work together, let's partner, let's find some answers. Unfortunately, I think in some ways we're still stuck in this stage. It is important to raise awareness. This talk is part of that. But I think we really do need to begin shifting towards research and policy that will really address what do we do today. It is important to talk about what we're talking about and how we define autism and the question of an epidemic or rise in incidence. This was the most recently published governmental data from the United States, from the CDC. They published through what they call MMWR. It's their publication about public health notices. And it talked about the prevalence of autism spectrum disorders, monitoring from different sites around the country. They cannot survey every single community in every single state, so they take areas and they pull together and estimate. There were 14 different sites, and this was done in part by telephone interviews asking parents about diagnosis, and then in some cases verifying diagnosis professionally. So it is important to know how these surveys are done. The bottom line was that based on this updated survey, the national rate of just kicking out? Yeah? Just going in and out? Yes. Yeah? Can you all hear me anyway? The rate was estimated at 1 in 150. That was an update previously from 1 in 165, all children, rates of new diagnosis. Doesn't talk about why, doesn't talk about where, but that is what the number that's published most recently. The interesting thing is it really varied from state to state. Now this data, this slide, it's really not intended for you to be able to read the whole slide. I have the reference listed that I'll show you, and you can go online. This is a privately done estimate based on special education data, state to state, and it's much more recent. It's for 2007-2008 school year, and looked at state rates. And at the very top, Whoa, that was too fast. Let's go back. I don't think it wanted to show you. Minnesota at 1 in 74 children. And so Dan Hollenbeck, that does this work, and again, you can find it on this website that should be in your handouts, will actually go through many states county by county and can look at where the reports are. So certainly here, and if you go down about 5 states, you'll find my state of New Jersey, so we're not far behind. Many of these rates are between 1 in 75 and 1 in 100. We find that the numbers continue to increase. This is California data published several weeks ago. It's from 2007, but California is the state that does probably the best job of overall state counting. And the interest has been in looking at the rate of change. And so if you look from 1987 to 2007, there continues to be a rise in the rate of increase continues to rise. People will speculate why that is. We don't have enough time in the whole day to come to an answer about why that is. The conventional explanations have been things like, well, the diagnosis shifted around about 1994 when the DSM-IV changed its diagnosis, broadened the categories. Autism now includes autism spectrum disorders such as Asperger's syndrome, pervasive developmental disorder. So we expected some widening in diagnosis. Take a few years for the educational systems to catch up, more awareness, and that is part of it. But we are now 15 years later. And to look at diagnostic shift, are we taking kids who were labeled something else and now calling them autistic? What this California data shows that since early on in 1987, the blue line is the rise in autism. Mental retardation, which is what is classically thought may be shifted over, hasn't decreased similarly. All of the numbers were fairly low, and they've all increased somewhat, but we haven't seen a curve that would be predictive of a complete diagnostic shift. For a full explanation of contributing factors, the Mind Institute, I know you had a speaker here from there, has done some great epidemiological work, just published this year, looking at the incidence and the reasons why. And the conclusion really is these kinds of things do not fully explain observed increases. There must be other factors. Of perhaps greatest concern, this is the future projection of increase in California. And this is done really quarter by quarter. So despite measures to explain, to intervene, we are not making any headway in new cases. The projection in California is that, I don't know if you can see the number at the top, but it's to exceed 50,000 cases. Oh yeah, okay. We'll have a backup system. It's also important to say, what is it we are talking about? What is autism? How do we define it? It means different things to different people, and it means different things over time. In 1943, Leo Kanner and Hans Asperger were two of the first clinicians to describe cases of children who had behavioral, social, and communication dysfunction consistent with what we now think of as classic autism. Bernie Rimland in 1964 was one of the first people to look at autism as more of a biological disorder. And one of the greatest services he did for parents was dispelling the myth of the refrigerator mothers, the Freudian explanation that children were autistic because of bad parenting, which is horrific. And Bernie was really one of the first people to say, no, let's look at these children. This is a complex medical disorder. There are things happening in the brain, in the body, that may explain behavior. In 1994, we had a much better description of what we were seeing in the DSM-IV, and there are revisions ongoing ever since for DSM-V, which every year they say will be coming out that year. A lot of debate about what that will include and what that won't include and how relevant that will be to practice. Indications are it will not change the definition in any significant way, but it really was a framework that many of us use. But again, that's 15 years ago. So what do we need today? We have an abundance of data and research showing we do need a new model. There are complex interactions. I know that many of you work in fields that include therapeutics that are not specifically biomedical per se, but as a pediatrician, that of course is my scientific background. I'm going to address all of the therapies and considerations, but within the medical model, if you will, thinking of autism as a complex chronic illness, which is a controversial thing to say, there are these interactions in terms of behavioral components, what we see, neurological components. Many children have low muscle tone or seizures. Gastrointestinal disorders, which have been described at a higher rate in some subsets of children with autism. And immunological differences, including autoimmune and allergic disorders. Somewhere in the middle, and it's not the same for each child, is what we call autism. I found this in practice now, I found it very frustrating to try to make sense of all this. And so really as a way for me to put together my thoughts, the journal Alternative and Complementary Therapies invited me to provide, it's a review, and puts in writing a lot of the things that you'll hear about today in an updated form. So I do encourage you, if you're interested, to have a piece of paper with 4 or 5 pages and references that pretty much does explain it, and it for the first time described a model that I call the iceberg model that you'll see here today. What is this integrative medicine we talk about that I practice, and why might that be seen as part of the solution for how we address autism? These are many things that are native to holistic healthcare practitioners and really pediatricians in general, but just as reminders, this idea of the whole child. I called my practice the whole child center. The whole child is really a concept I did not invent. It's been around a long time, but it's holistic care. The child is not just a physical being. They have interactions with family, with community. They have mind, body, and spirit interactions that reflect health and optimal health. Family-centered care, so crucial when we talk about children's health. We cannot just address their single biological health. We need to really shift our system towards one of wellness and prevention, away from just acute disease management. We individualize therapies, and nowhere is this more important than in autism. One child with autism is different than the next child with autism and what they need, whether that's educationally, behaviorally, medically speaking, and we need to be comfortable with that. It is not a one-size-fits-all approach. Relationships, if anything, what I've learned over the years is that my relationships with families are probably the most important aspect of the healing encounter. The process of what I do and how I do it, and paying attention to that and what they give me, it may be as important as anything else we do. Collaboration. Many of us here today come from different backgrounds, professionally, personally. Some are parents, some have autistic children, some have nephews, nieces, cousins. We must all work together. There is no way that we are going to be successful without partnership. I've been encouraged in autism, unlike any other area, do we see parents getting involved at the highest levels of science and research and advocacy. What are conventional therapies? If we're going to talk about alternative and complementary therapies, when we talk about integration, it is really the best blend of both. And so I don't want to ignore conventional therapies, but again, we can spend the entire time talking about these. I've listed some. If I've forgotten anything, I apologize. At the top of the list, when parents have a child who's newly diagnosed, we usually start talking about education and behavioral shift, and that is where most of the data and research has been. There is, of course, controversy about how many hours and what types of settings, and will one child do well in one versus the other, and how many hours. There are, of course, legislative and economic issues with that. But I think to ignore that those are probably the two baseline things that we start with is important. And practitioners that integrate what we call CAM, or complementary and alternative medical therapies, for the most part, do not ignore those things. That is a crucial part of what we do. There are other behavioral therapies as well, floor time and RDI, of course, speech and communication, occupational physical therapies. We are looking at all of the core constellation of symptoms that we describe as autism behaviorally: language, communication, social, and behavioral. social skills groups, other psychotherapy and other psychological interventions, cognitive behavioral therapy. Some of these are symptom focused, others are broader. And I put at the bottom medications, which you usually would put medications in a conventional therapy list. But I wonder in autism if that really belongs there. If we look at the level of data of long-term support and data for safety and efficacy, I wonder if there is as much data or less than some of what we call complementary and alternative medical interventions. And so in one of the models that we look at in integrative medicine, we're trying to look at everything equally. Look at data, look at safety and efficacy. Now we start to get to the meat of what we're talking about, CAM therapies. And CAM is a word that's just a sort of garbage bag term, garbage pail term for all of complementary and alternative medicine therapies. Most of you may be familiar with biomedical therapies. This is where most of the data is, most of the theory, and what most families get into first. That's where we get into nutrition and diet and supplements and other therapeutics. The groups that have been the greatest proponents of this over time are the Defeat Autism Now, Autism Research International Group, Institute for Functional Medicine, and then there are eclectic practitioners such as myself that draw on a variety of different biomedical theories and thoughts. There are other CAM therapies as well. I will also cover those. Why are we talking about this? I appreciate that you invited me here. I like that. I'm very happy to talk about what's a really important issue. I'm sad that it's so much in the news and it's happening to so many kids. But the reason we talk about alternative and complementary therapies is because that's what people are doing, and they're turning to those for various reasons. One survey that I did a few years ago was based on 2 different primary care practices, and it's different than some of the other autism surveys that were more specialty center derived. What we found in our practices, and yes, there is a bias towards when you have an integrative practice, you will have families who seek you out for these reasons. The other practice was based at an academic medical center clinic. Over 90% of families were using some form of CAM therapy. When you look at other surveys, it ranges from anywhere from 50% up to 90%. It's the vast majority. And unfortunately, many families are not telling their primary care providers. Why? Why are families using these remedies? Well, it's based on their beliefs. There's been some really interesting literature looking at family beliefs and physician beliefs, and I know Allison Golnick is going to talk somewhat about that later too. The other thing is, frankly, like other things we're seeing in pediatrics today, autism is a complex, multi-systemic medical disorder with no conventional cure. So those are the types of conditions for which parents are more likely to seek outside of the medical system. Mercer's study in 2006 looked at reasons why parents thought their child had autism. Very illustrative. You would expect things like genetic influences and perinatal factors to be up at the top of the list. But over 50% also believe nutrition played a role. That's important for us to know. You also see the 40% vaccine number. I'm going to spend very little time on that today because, again, I think we would be here for a very long time. And in questions later, I'm happy to touch on that. But I think it's important we know what parents are concerned about. Greg Liptak did a really great study looking at how satisfied are parents of children with their primary care providers? And what was it that caused their dissatisfaction if they were? One of the key things that came out was, and this was really unsolicited, and it wasn't his primary theory in writing the paper, where parents requested more information on CAM therapies and more support for that. They want their providers to know about these things, not necessarily endorse, but to discuss and talk about. So one of the ways we tried to promote this was the American Academy of Pediatrics took this poster, endorsed it from the Canadian PedCam network that developed it, and Sunita Vohra in Alberta, who developed this wonderful poster. I have it in my office, actually, in all of the exam rooms. It's in French, it's in English, it's actually been now translated into Dutch and can be translated into any language The Canadian group is happy to work with anybody who would like to. And it simply is an open, it's a invitation. It says, hey, talk to us. It's a very simple message. It's beautifully done. And you can actually, if anyone can't find it based on the resources I've listed, please email me. I'll be happy to connect you. Are there ethical issues? Just by talking about alternative and complementary therapies in practice, yes, of course there are ethical issues. One of the questions that usually comes up is, well, how do you discuss financial issues in this time, especially economically, where it's so difficult for people even to just buy food? How do we discuss within these therapies that are, for the most part, out-of-pocket expenses? Interestingly, if you look at U.S. expenditures, the out-of-pocket expenses for natural health products exceed visits to primary care physicians in terms of the patient contribution to that, putting insurance aside. So people do make decisions that this is what they want to do. However, as a physician and as healthcare practitioners or educators, how do we address this? I really like this simple model from Kathy Kemper, has talked about from Michael Cohen and David Eisenberg. If something is safe and effective, we would typically advise the use of that therapy, whether it's alternative or conventional. If it's not safe and not effective, we would advise against. Those are the two easy ones. The other two categories are more tricky, and when we talk about many of the therapies we talk about here, either will fall into one of those two categories. Either they seem to be safe or generally recognized as safe, but have questionable efficacy, maybe small pilot studies, or there's been no research done. That could be something like yoga, for example. If something is documented to be effective, but of questionable safety, well, that's a tricky place to be too. How do you analyze that risk-benefit ratio? That needs to be a decision and cautioned and monitored. A couple of great reviews. Again, they're in the handouts. I was privileged to edit a volume of the Pediatric Clinics of North America, which they do monthly volumes and subjects in R1 and Integrative Pediatrics. Wendy Weber and Sandy Newmark did a great chapter reviewing all the literature. So it's a great chapter to read. And Susan Hyman and Susan Levy did a review in child adolescent psychiatry clinics as well. What are some guidelines? Again, I'm not going to go through this in detail, but we do have guidelines looking at the use of complementary and alternative medicine in children from some reputable places. The American Academy of Pediatrics, which in some circles in autism has been criticized heavily for their lack of attention to other therapies. On the other hand, the group has allowed us to form a section of integrative medicine within it. We do have 60,000 pediatricians who are now listening and looking at data. Kathy Kemper and others of us were able to put together a statement that was published last year drawing attention to these issues. Even within the statements just on autism spectrum disorders, we now have people who are looking at CAM interventions and basically encouraging pediatricians to have these discussions with their patients. One of the greatest things to come out of this work, and again, Dr. Golnick will go into more detail, is what's called the medical home. This concept, if you're not familiar with it, is really to provide a home in the medical setting that is multidisciplinary, continuous, accessible, comprehensive, so that families feel like they have a coordinated care system, which is especially important if you have a child who's autistic, who has cancer, who has asthma, some chronic healthcare condition. Unfortunately, those children with autism are less likely to have a defined medical home than others with special health care needs. And that's obviously not right. So, we've now talked about some frameworks for integration. You've been fooling around with alternative medicines, haven't you? So this is the sort of historical approach that many physicians have taken with alternative medicine. You've got this big guy here glowing. Let's have a different model. It's time for a change in our paradigm. I find this model helpful using an iceberg. To me, it made sense. I've been able to use it to describe, both for families and professionals, looking at autism or other chronic healthcare disorders. You have different components that reflect disease or disorder, if you will. At the bottom of the iceberg are our genes, genomics. perhaps what we're born with, not that these are immutable or unchangeable, the expression of which, genes are expressed in different ways. They're expressed prenatally, they're expressed postnatally. There's an influence on the genes, and they express and develop proteins and metabolites through different reactions, which we call proteomics and metabolomics. These are all things happening, if you will, below the surface. The phenomics, the phenotypes, what we see above the surface are the behavioral, social, and communication deficits or differences that we see in autism. That's what we describe. That's what parents describe to us or we see. What's happening to influence those changes? This is not a static model, but there is an influence on one to the next to the next. We have started looking below the surface, under the hood, to see what's happening, where can we influence this pattern, at which step? Because already there are influences. This is my favorite part of the slide here. You get these, PowerPoint is great sometimes. These triggers, these lightning bolts, are environmental, very broadly defined. Something happens to influence, whether it's prenatally, perinatally, postnatally, even on the genetic level, and causes a shift and a change. Take a sidelight briefly, and I'm going to come back to this a little bit later. So, environment. More and more data, a very controversial area, because when we talk about environment, we talk about things like mercury and lead and even vaccines. But when I think of environment, and Martha Herbert, who's at Mass General, and Richard Lathe, who wrote a book on autism, brain, and environment, when we look at environment, we think of everything in the environment. Those can be social factors in the environment. They can be infectious things in the environment. So this really shouldn't be a controversial topic. Clearly, some of the component of the rate of rise of what we're seeing is environmental, however you define that. How does that work? Well, a really hot area of research is in epigenetics. So we talked about genes. Is autism genetic? Of course, in part it's genetic. Everything in part is probably genetic. But there's a complex interplay of interactions which is different for you and for you and for you and for me. How the expression of our genes are, and it's something we never really thought about, that if I'm born with a certain genetic makeup and I express and I go through my life, it's predetermined, that's what's going to happen. That's clearly not the case. There are key points in development, again, prenatally and postnatally, where we can change not only the expression of genes in an individual, but how I pass on those genes. And so you may see over time exposures that become condensed and crystallized. This is some of Martha Herbert's work talking about in the Environmental Genome Project. This is being done at the highest levels, and it's influencing many different types of biology. So brain effects, indeed, in autism may be downstream of genetic vulnerabilities or gene-environment interactions that affect other organs or whole systems. Think about that. That is a completely different shift in how we think about the biology of autism. One of the main nonprofit groups that looks at children's environmental health has a subgroup for Learning Development and Disabilities Initiative. This was a statement by many scientists, similar to statements you see on global warming or others, stating the scientific evidence we've reviewed indicates environmental contaminants are an important cause of learning and developmental disabilities. A recent review talking about this concept called Occam's razor, which is really looking for the simplest unifying solution, is a great review to read about the contribution of neurotoxins to developmental disorder and disease. Why are we so worried about this? And it's not just autism. As the Environmental Working Group has put out, when we look at, it's a horrifying term, pollution in newborns. They looked at the number of chemicals, pollutants, and pesticides in human umbilical cord blood at the time of birth. In 10 babies, because the cost per baby to do this analysis was $10,000. They found a total of 287 chemicals present in cord blood. Chemicals that have known contributions to carcinogenesis, neurotoxicity. In what levels, we don't know. In what amounts, we don't know. Mixed together, 1, 2, 3, 10, 100, we have no idea. These are some of the list of things that were found. Out of the 287 chemicals, you can see the list here. I don't want to belabor the point. What is the status of these chemicals in testing? Do we know they're safe for kids, or are we just finding these things and we don't need to worry about it? Well, out of the almost 3,000 chemicals produced above 1 million pounds per year, these are only the ones produced above 1 million pounds per year in the US, and this data is a few years old. 20 to 30 were tested for neurodevelopmental toxicity according to EPA guidelines. There's no data on 78%. So what do we need to do? There's an act being reintroduced called the Kids Safe Chemical Act. I would encourage you all to look at this, and really requires people to look at the impact on children's developmental health. Again, we're here to talk about complementary and alternative medical therapies for autism. I get that. That's going to be mostly what we talk about. But I think if we're talking also about prevention and wellness and contribution, I think this is an important thing to cover. So, let's talk about biomedical approaches. When I mentioned this earlier, I talked about functional medicine and other approaches. When we talk about biomedical approaches, it's looking at that below the iceberg, the metabolomics, the proteomics, the gene expression. I put this slide up, and it's a face page of this recent review, not because it's really earth-shattering in its content. It's a great review of neurometabolic disorders and dysfunction in autism, of what we know today, what we don't know, what research we should do. It's a great little paper. But the author, the main author, Sarah Spence, comes out of the National Institutes of Health. This is being looked at the most conservative, routine levels. We are starting to ask the right questions. I find that encouraging. To break it down into different areas, gastrointestinal and nutritional, immune dysregulation, changes in metabolism and in mitochondria, and oxidative stress and detoxification. And when I talk about these areas, I want you to understand, unfortunately, a lot of this is still at the theory stage or small pilot study stage. Parents will say to me, well, that's great. What do I do today? Bless you, what am I supposed to do? So there's a challenge in practice when you see clients or patients today to say, well, if you wait 10 or 15 years, we'll have good data. What kind of data? I'm not trying to be flip about it. I mean it. It's a challenge, and ethically, so each practitioner has to find their way and what their comfort level is. Let's turn to gastrointestinal issues. Probably the number one utilized, if you will, CAM therapy is nutritional change and modulation. Just a quick show of hands, how many people have heard of the GFCF diet? Yeah, I mean, it's a majority of people, gluten-free, casein-free. If you did that 10, 15 years ago, it would be a minority of people. And it's worked its way into other areas and not just in autism. Many researchers have described a frequency of gastrointestinal disorders and symptoms with autism that range from diarrhea, constipation, abdominal pain, esophagitis, gastritis, intestinal inflammation that seems to exceed sibling match controls in the general population. And it is described everywhere through the GI tract. This slide shows possible mechanisms for that, where connections between, well, why is this happening? Things that cause gut inflammation are probably what are linked to this. What the etiologies are for that are numerous. The evidence, again, is all through the GI tract, from, again, from the esophagus all the way down into the stomach, through the small intestine and large intestine. And we have found evidence of differences in intestinal lymphocyte populations and inflammatory bowel disorders. There's, in the mucosa, in the lining of the intestine, there is inflammation. The cause of that has been speculated to be a number of things, but we think about, well, what goes into the gut? Food. Are there foods that when you eat them cause gut inflammation? Well, sure. We see that in a lot of other circumstances. We see it in newborns who have allergic reflux or eosinophilic esophagitis. They have inflammatory esophagus disorders that are sometimes caused by food allergies or sensitivities. There are a number of kids, many kids, who have sensitivities to different foods, and you know what? They get stomach aches or they get stomach pain, and if you look, you may find evidence of inflammation. So it was postulated that several foods, gluten, meaning a wheat-type protein, and casein, which is a milk cow's milk type protein, might be the two biggest offenders. Why those two? Parents describe that when their children ate those foods, they may have had worse stomach symptoms, worse behaviors. And so a number said, well, let's take those things out. Let's see what happens. That's how it all started. There has been elucidated a mechanism which says that for some children, is it possible that these foods trigger an inflammatory reaction along the lining here, leading to these large proteins, the casein and the gluten, to pass through, get into the bloodstream, and cause an opiate-type effect in the brain. That's the theory. There has not been great study or data showing this is in fact true, but parents will describe over and over again this cloudy effect or different behavior when they eat cow's milk and they take it away. There's a difference. So that's the GFCF diet. There are others as well, where you eliminate other foods. And so you say, well, that's great. Should all kids who have autism be put on a GFCF diet? Again, as I said in the beginning, autism isn't one thing. It's very clear that there is not one thing that's going to work for everyone. And it's not a simple thing to do. To remove all traces of gluten and casein is extraordinarily difficult. And it can be anxiety-provoking, it can be expensive, it can be difficult to access. So when we work with parents, we explore it, we talk about, is this child perhaps within the phenotype who might benefit? In the end, if a parent says, well, test my child and show me that he should or she should do it, I can't do that. I can look at some data and try to help them. But in the end, it often is a trial, like an elimination diet that we do with many disorders. Try off, I'll give you support nutritionally, and we'll talk about what that means, and see if you notice a difference. You must have endpoints. We had a nice discussion last night with Dr. Vora, who's a researcher looking at studies that are N of 1 studies, where you take each individual patient and do crossovers, where you do them on and off, blinded, to try to see if the intervention makes sense. That may be the way to go, but we do need to address it. It is what a lot of parents are doing. The role of food allergies and sensitivities, people ask, well, can I do blood panels? Can I see, are they sensitive, are they allergic, are there urine tests to do stool tests? Classically, people will look at IgE, which is a classic food allergy-mediated reaction. That's when you'll see an acute reaction. Probably not the greatest source of food reactions, but there do seem to be described more classic food allergies and other allergic disorders in children with autism. So clearly, if you are allergic to peanuts, you don't want to have peanuts in the diet. Does that mean you'll see a behavioral shift or change? Maybe, maybe not. We don't know. You must track that. And I think that's where the connection between behaviorists, physicians, teachers, where we all collaborate together with families to monitor changes. And I think those are the outcome measures that are going to be best served when we can measure what's happening. Many different supplements are used. In vitamins, minerals, looking at amino, organic, and fatty acids, probiotics, and enzymes. Just to talk about vitamins and minerals first. Several studies looking at high-dose vitamin B6 and magnesium to support neurologic function. The Cochrane database review that does systematic reviews in 2006, I believe, or 2005 was the most recent, basically said, as a lot of them do, we don't know. Some data on one side, some data on the other side. Many of the multivitamin products contain high levels of B6 and magnesium and are marketed as autism vitamins or ADHD vitamins. You just need to be careful because they can be quite overstimulatory for some kids. It's not the answer for all. May be helpful for some. The B12 story is very interesting, and folic acid. These are methylating nutritionals, and I'm going to have more data on Jill James's work with, are there people who genetically need more folic acid or B12 than others to optimally function? The answer is yes. Who are they? We're trying to figure that out. And does giving those therapies lead to measurable, sustainable behavioral change? Vitamin A also been implicated in terms of visual disturbance and ocular focusing and visual processing disorders. Toxicity is an issue with high-dose vitamin A. You have to be careful. Vitamin D, so both of those, A and D, are found in cod liver oil that many kids take. Big discussions about vitamin D deficiency. It's now been linked to almost everything. Is everyone vitamin D deficient? Maybe. I don't think I've seen and drawn a normal vitamin D level in a long time. I'm in a northern climate as you are, not as north, thankfully. I like skiing, but so what if we measure in the summer versus the winter? What level's right? What level's right for me? What level's right for you? But there does seem to be a relative change in vitamin D status. And does that make a difference developmentally? Calcium as well. Also, because if you're restricting your diet from cow's milk, how do you provide calcium and vitamin D? Vitamin C, E, and selenium as antioxidants, very important. Better to get in food. A lot of kids with autism aren't great eaters. How do we get them to do that? Sometimes we use supplements short term until we can improve their nutritional status. If all you ate were 2 different foods and they had white flour in them and that was it, how do you think you would be thinking and feeling? I'm not saying that causes autism. And again, I'm not trying to be flip about it, but I do think the role of nutrition in developmental disorders is in part because the brain food isn't there. There's sensory issues with eating. There are issues around absorption. And so sometimes we do need to use support to help kids get to a healing stage. Iron also equally important. And zinc and copper is interesting because zinc deficiency in and of itself is a problem with ADHD and autism. We see more kids who are zinc deficient, maybe dietarily. Zinc is added to grains, it's enriched. But many people have a genetic predisposition towards low zinc, high copper. It's in the metallothionein complex coding, which has to do with detoxification. So it's very interesting when you start to put these things together. And by giving zinc, you lower the copper and you have less toxicity. Amino organic and fatty acids, these are just some surveys that have shown differences in panels. It's not, if you're a geneticist or a metabolic expert, you may say, well, you know, if you look at these aren't classically described inherited disorders of metabolism. They're differences, though. Lower homocysteine in some cases, lower essential fatty acids, omega-3 fatty acids. Different patterns have been found. So why do fish oils or omega-3s sometimes help people with depression, bipolar disorder, anxiety, OCD, autism, ADHD? Why is it becoming more mainstream? Well, there may be differences. Are they genetic? Are they environmental? Are they both? Probiotics, something that really is not so much alternative anymore. Well, you buy it in half of your food now, right? Classically looked at in pediatrics for antibiotic-associated diarrhea, for prevention of that, for treatment of infectious diarrheas. Well, one of the things that happens when you have gut inflammation is you get overgrowth of strange bacteria. Clostridium and other bacteria can develop that cause further inflammation and poor absorption. This has been described in some very small studies in autistic children and in children with inflammatory bowel disease otherwise, and using probiotics to modulate that. Probiotics also have been found to modulate immune responses. So it's a fascinating area for research and intervention. What else happens with gut inflammation? You may distort enzymes. People that are lactose intolerant don't have enough lactase. They don't have enough enzyme. That happens genetically over time. There are other enzymes that help digest foods, such as milk proteins and wheat proteins. The DPP4 enzyme is one such one, has been described in certain cases to be deficient, and you can buy enzymes, parents often will, and give them to kids before they eat that contain a variety of enzymes to help with digestion. Sometimes it may be an aid to help with absorption. Again, I think of this as a short-term intervention until we can help improve nutrition and diet. There are no RCTs that have been done. How are we doing on time? We're good? Yeah? Okay. Immune dysregulation, a big area. Tied in with gut physiology as well. This is all tied together. Children with autism, a number of them, again, not all, but a subset, when you look back at early histories, a child who subsequently is diagnosed as being autistic, there are higher rates of upper respiratory infections, lower respiratory tract infections, acute otitis media, or chronic serous otitis media, ear infections. You'll see these phenotypic kids who present with a lot of infections early on, irregardless of they're in daycare, they're out of daycare, other factors. There seem to be immune disturbances, and this is described in the Niehaus and Lord study. In one study recently, you say, well, why is that? What is it about their immune system? And it's true of non-autistic kids as well. But in these kids, in some, there were reduced levels of those major antibodies that fight infection, immunoglobulins. There are differences in immune development and immune regulation. And so when you look at, I'm going to come back to this, well, you may see early warning signs as well in these children, not just colds and recurrent ear infections, but things like eczema, reflux, allergies, and asthma that present in these children. This is the other side of the immune seesaw that we'll talk about. Family history is very important. Many children have a different maternal family history of autoimmune disease and allergic disorders. So what's happening? Are these predispositions that, given the wrong environmental circumstance, shifts children in one way developmentally? Are these the under the iceberg here? The immune system, and if anyone's an immunologist, and I said this yesterday too, I apologize, this is a gross oversimplification of the immune system. It's not a simple seesaw, but it's helpful to think of Th1 and Th2 like a seesaw. One part of your immune system, and there's many interactions, if it's dominant, if it's too high, the Th2 system may lead towards autoimmunity and allergy. Your body's throwing out lots of things to interact with the environment inappropriately. Foods, viruses, you name it. Itself. Th1 is more immunity to help fight infections, to really simplify it. So if it's distorted or dysregulated, you may have a child who has lots of rashes and mucus production and allergy, autoimmune stuff going on, and yet not able to fight off routine infections. I've seen combinations. I've seen kids who don't really get sick much but are very autoimmune, and kids who have neither. So trying to subtype, that's really important. And this is linked to gut physiology as well. The major area of immune populations of cells is in the gut. There are lymphoid patches that can get inflamed from overproduction, causing gut distress. It's been described in relationship to dietary proteins. Is this the missing link? We eat a food, it disturbs our immunology, causes inflammation in the gut, poor absorption, nutritional deficiencies, developmental change. That has been described in areas such as celiac disorder, which is a strict gluten sensitivity where you cannot eat gluten in your diet. What happens? You get a gut inflammatory disease, you have micronutrient deficiencies, and you can develop neurologic disorders in subsets of people with celiac disease. Not all. Some have seizures. So there are mechanisms that have been described. To turn to metabolism, that metabolomics, again, no one, even people out there, you're not supposed to be able to see this and read it in entirety. This is a pathway list that's supposed to look overwhelming and confusing, because it is. And in biomedical circles where people look in functional medicine and defeat autism now, these pathways are hotly debated about which factors can be influenced in terms of metabolism and biochemistry. If I add folic acid here, what happens here? If I add methyl B12, what happens here? The common pathway ends up leading towards certain amino acids that support glutathione, which is a major antioxidant and detoxification molecule in the body. And that's one of the endpoints. There is also DNA methylation involved here. So there's many different fascinating theories. How can we intervene? And some people have started to look at that. You are here. That's homocysteine. And when we look at homocysteine and carbon metabolism, we start to look at, all right, now we get to put together some genetics, some proteomics, some metabolomics, and some phenomics together. You have someone who may be genetically predisposed. Jill James's work at Arkansas talks about how there are single nucleotide polymorphisms present in subsets of children and families with autism. They regulate carbon metabolism. The MTHFR gene, for example. In adults who have mutations, and it's not like you're going to see a major thing happen if you have that mutation. It's not like Down syndrome. What you may say is there are differences in enzymes, and as an adult you may be more prone to heart disease or cancer. Children with these mutations may be more prone to neurodevelopmental disorders. But if you can override that, giving folic acid, other methylators, can we bypass those nutrigenomic differences? Well, Dr. James looked at this in small pilot studies. The first study looked at, we measured differences in this carbon metabolism, differences in glutathione, homocysteine, cysteine, sulfation molecules showed that some children with autism were different than their sibling matched controls. By giving methyl B12, by giving folinic acid, and by using another methylating nutritional compound, she was able to show that we can normalize these values. Well, that's step one, right? Step two is showing observable developmental differences and behavioral differences and safety, of course. And so these are underway. Again, she is partnering with an ABA group to measure outcomes, and I think it's really fascinating work. We also have mitochondrial dysfunction to bring to this. Mitochondria, those little energy battery packs in the cells. We take a little detour here because mitochondria become hot topics in metabolistic research, in metabolic research in autism because of Hannah Poling, a young girl in Atlanta whose case was publicized because of a settlement she received from the government. She developed autism. The case claimed resulting from numerous vaccines on the baseline of having a mitochondrial dysfunction. Whether she had it before the vaccines or after, no one knows, but it brought to light this concept of vulnerability. And it's not just vaccines, it's other environmental factors. If you have a vulnerable child who may have a metabolic or genetic difference and certain things happen at that time, there's a timing issue. Do they change developmentally? Well, it's reasonable to think that might happen in some cases. Used to think that mitochondrial disorders were very rare in children with autism. It turns out now if we look at the definition more as dysfunction rather than disorder, subtler changes, maybe 30%, 40% in some surveys. Is this another area? If you give these children carnitine or CoQ10 as an intervention, can you normalize their mitochondrial function, get them functioning more appropriately, and then change the way that they interact with their environment? We don't know yet. What happens as a result of all these metabolic derangements? We develop oxidative stress, free radical development. It's why we talk about antioxidants, to try to help our bodies rid themselves of free radicals. And the body does that pretty eloquently when you're in balance. In one side, you have oxidative stress happening from environmental toxicants and antioxidant defenses, a nice balance. And many of us do that fairly well. Unfortunately, on that right side over there with all the stressors, we have many more of those today than we had 100 or 200 years ago in terms of environmental contaminants. So what happens? Sometimes we see a shift and we get cell death damage, which can be present anywhere in the body, but in the nervous system as well. It's been shown on a lab level with many different toxicants, including lead and mercury. But the concept is, if you don't have these defenses or you're unable to marshal them, are you more likely to have oxidative stress and cell death damage? The answer is yes. So people are striving to intervene. Unfortunately, the clinical practice is ahead of the science in this area. Again, it comes back to parents saying, well, I'm here, I want to do something today, I'm not going to wait 10 or 20 years. I'm not saying that's right or wrong, I'm just saying that's what's happening in the real world. So our bodies are set up to detoxify. We have many mechanisms to do that. You can see the circle down there is where you have free radical formation. You use glutathione and other components to rid ourselves of toxins. What are some of these toxins? Well, this is a slide from Texas, which looked at rates of autism on the right-hand side, mapped with total toxicity, environmental toxicity, specifically pounds of mercury release in the air. The maps match up pretty well. In the Bay Area, in San Francisco, there was a relationship between air pollutants, individual compounds including mercury, cadmium, nickel, etc., and vinyl chloride, which I'll come to next, potential association between autism. Again, these are not saying cause and effect, but associations in the air that we breathe. Pesticides, neurotoxicants. Autism risk increased with the poundage of organochlorines applied and decreased with distance from field sites. There seems to be a relationship. Most recently, vinyl flooring. This was a study out of Sweden that they call it a baffling link because the researchers weren't really expecting to find this, but that homes with vinyl floors, which emit phthalates, PVCs, were more likely, twice as likely to have autism in the household, according to a new study accounting for other factors. Again, this is all preliminary research, but these point to ways the environment may be influencing factors towards development. These are areas we must pay attention to. What do some people do? Well, you can support natural defenses. You can support glutathione production. You can support antioxidant production by eating foods, certain foods. That's hard for many children with autism to do, so sometimes we talk about doing that through vitamins and minerals. You have to be careful. There are research studies in adults showing that too high levels of certain antioxidants may be pro-cancerous. So nutritional research is really difficult to do, but I think trying to work on supporting nutrition is key. Botanicals have been used for centuries and even millennia in China, in Japan, in many areas. There are herbal preparations, and in the homeopathic community used to help support detoxification. I don't have data to show you, but it's something that people will do and perceive as being safer or easier on the body. Again, it needs to be part of a discussion about asking what people are doing, and maybe these are ways that are safer than what we call medical chelation. And I mentioned physical things just as mineral clay baths and infrared saunas that people use to improve detoxification. Of course, there may be adverse effects, safety risks. I don't generally encourage families to do this, but these are things you need to be aware of. And chelation, using medical compounds, chelators, EDTA, DMSA, DMPS, to bind heavy metals in the body and help the body excrete them. They are conventionally used for lead poisoning in emergency rooms all over the world, but we have pretty clear definitions about how to do that, for whom to do. One thing no one's ever proven is that by doing that, the outcome, how you do developmentally, is made any different. No one's ever shown that you can improve IQ or you can improve differences. We do it for those because it's the right thing to do and it's not healthy, and these kids are sick acutely. But on a more chronic exposure, one of the questions I have is, does it seem to be healthier to remove toxins? Sure. But is there a cost-benefit analysis we're not looking at? Does it really make a difference in the end? And how safe is it? Quickly mention hyperbaric oxygen treatments, HBOT, in the news a lot lately due to one study that was published looking at why would people do this, looking at a chamber that you go into at a higher partial pressure of oxygen. This study looked at 24% room air, so air oxygen slightly higher than room air concentration. Often parent will go in with the child into the chamber for an hour at a time for these dives that happen once a week or so. Parents are purchasing these for home use. The theory is that there's decreased cerebral perfusion, increased inflammation, oxidative stress in the brain, and that we can improve these things through using hyperbaric oxygen. It's been used in other medical things like barotrauma and burns. Rosen et al. Published their study recently in BMC Pediatrics, which was, it was a well-done study, and showed some really interesting preliminary findings and improvement, and certainly bears further research. But it is certainly, if you look at that map of safe, effective, it is certainly the safety issues need much greater research until this can be recommended on a broader scale. People use CAM therapy symptomatically for sleep. One of the areas practitioners start to feel comfortable using other things are for symptoms, for sleep, for anxiety, other things where they can specifically target, where parents may not want to use medications or medications may be inappropriate. So something like melatonin, which I've given a few references, has been used widely in children with developmental disorders, children with seizure disorders, found to be safe. Dosing depends. Most people start at about 1 milligram and give it about an hour or so before bedtime, although some people use much higher doses or much smaller doses. Some children don't do well with it. They're more agitated. But it's felt to be, it's generally recognized as safe and maybe one of the sleep aids. Aromatherapy, using lavender, which I have here, or other scents, may be relatively easier ways to help with mood and anxiety and sleep. Additionally, and I'm going to just roll through this because I only have a few minutes, these are some of the many other therapies. I don't want to give short shrift to any of them. Sensory integration therapies, hippotherapy, creative arts, expressive, Chinese medicine, acupuncture, manipulative therapies, chiropractic, osteopathic, craniosacral, and massage, homeopathic, Reiki or energy medicines or yoga, all are being used in children. Sensory integration therapies as part of occupational therapy, very widely used, specifically auditory and visual processing disorders. Some data limited, looking at pilot programs. Most importantly, parents report success in terms of feeling that their child is making gains. Many children do seem to have sensory input issues, and it is a common part of plans. I think it's a lot less controversial than it used to be. Horse riding or hippotherapy. Great new book that came out recently about a dad who took his son to Mongolia. He grew up in Texas, and the child did great riding his horses, would speak while riding horses, but really had trouble with communication, severe behavioral disturbances, but did really well on the horses, so took a trip to Mongolia. Rode horses, met with some of the local shaman there, and he describes his experiences. Is this a generalizable phenomenon? No, that's not why I put it there. But many kids do find value from relationships to pets or horseback riding therapy specifically. In many hospitals now, we have creative and expressive art therapists, music, art, dance, writing, etc. Music therapy, some really interesting studies and meta-analyses that show a very nice effect. Some children really enjoy music and sound. Chinese medicine, well, if you look at the Chinese literature, when we talk about CAM, or conventional medicine for that matter, herbal and acupuncture are a big part of what they do there, and they've looked at that. And that was one of the most common types of CAM use there for autism was acupuncture, sensory integration, and herbal Chinese medicine. Almost 80% expected CAM to augment conventional treatment, so this is happening all over the world. Parents will turn towards other therapists for touch therapies or energy therapies, manipulation, limited data again, but some effective positive touch. Homeopathy, fascinating theory, and if anyone's interested otherwise, we can talk about that. Blends of different remedies, when you use them, they're help for detox, they're help for behavior, speech. It doesn't make any sense in any rational way in Western medicine, but there are parents for whom that is the only alternative therapy they do. This N of 1 study design I described may be a useful way to look at this. And some data starting to happen in yoga. We run yoga classes in our center for children with autism, and I can tell you there are 4 boys right now who all come together. They have a great time. And the parents say they sleep better those nights, they interact with each other better. So there is this need for a new paradigm. I think that this is probably a good place for me to take a break, and we'll take a break now, I believe. Yeah, and we'll come back afterwards. Thank you. So I realized we had a little bit more time, and I did want to go back. So I'm going back in some of the slides because, I didn't want to give too little time to some of these very important therapies that many families are using as a complement to the other work they're doing. And there's some interesting research starting to develop in these areas. These are areas that typically are performed by other healthcare professionals such as occupational therapists, pet therapists, creative arts, child life people, of course Chinese medicine practitioners, whole fields of chiropractic and osteopathy and craniosacral and massage therapy, homeopaths, energy medicine, and yogis. And what's interesting is these are not areas that people were typically trained in our Western research epidemiological methods. And so there are now conversations happening, even on the medical school level, between many of these types of therapists and more conventional physicians about what types of research should we be conducting? How do we honor the intention of these therapies? What are appropriate outcomes? So I think it's really an interesting time, and if anyone practices in these areas, there are ways to join now practice-based research networks to do this work. So again, to come back to sensory integration, what that is, many parents will describe that children have differences in the way they process information. That can show up at very early ages as texture tolerances, feeding differences, position in space, pressure, touch. Some children with autism like very firm touch, others abhor it. Same with sounds. Some like very busy environments, and they thrive on that. Others cannot stand it and will hold their ears and show great distress. And so therapies have been devised to try to help these children reintegrate these stimuli. One other note about hippotherapy that I mentioned, there's a website that's referenced here that you have in your slides. Dr. Beverly Kane is a physician at Stanford who, this is her site, which is called horsesensei.com. It's very interesting. And it's this mixture of pet therapy, working with horses to help heal people, but also helping caregivers and physicians. This idea of healing the healer and relating to patients through animals such as horses. It's a really, if you're interested in horses or horse riding, I would encourage you to look at it. In many of the hospitals that I work in, I know we have terrific child life therapists who practice many of these creative and expressive arts therapies, music therapists, art therapists. Now we have dance therapists and other creative arts and expression. With some of the higher functioning kids, we have reading, bibliotherapy, writing and reading. And their music, which is the one that I list here, does have the most research behind it. But you're also now seeing some nonprofit groups and others pop up to integrate in community healthcare settings, in schools, to encourage expression. Really, if you're talking about communication and expression, finding the other ways where children can express themselves. And many children really turn towards music or art and can be very gifted in these areas or just enjoy it. It's also a way, I want to go back because it just occurred to me, it is a way also we see many of them interact with their siblings and with family members. And a lot of times when you do family work, you find, of course, there's an impact on the rest of the family. And my wife is a family therapist, so she would shoot me if I didn't mention this, that obviously there's great need, as there is with when you have a child with any complex chronic healthcare condition, to address the family needs. The rates of divorce in parents of autistic kids is much higher than you would expect otherwise. There's a lot of difficulty in communication, and there's a tremendous effect on siblings or sibling. And so if we can find any way to encourage interaction and strengths, I find a lot of older siblings or even younger siblings can interact through nonverbal means, using art or music or dance to do that. We have, I think I mentioned yoga, which I'll come to. One of the classes we've done is where we actually have family yoga classes, and one of the members of the family may be a child with autism. One of the fellows I met with earlier this week as part of our research in integrative medicine meetings was a professor from Hong Kong who does research on traditional Chinese herbals. He happens to be an orthopedic surgeon, that's his training, but being Chinese and then doing work now in Hong Kong, it's interesting to talk about what are conventional therapies, what are alternative therapies, and in autism CAM work here, as I mentioned, a lot of our surveys show use of nutritionals and vitamins and biomedical approaches, and there, as you can see, it's very different. I was surprised by the sensory integration data, but it shows you that that is comfortable and part of culturally what they do there, and it may have to do with position in space. They do use Tai Chi and other methods to work with children with developmental disabilities, but far and away the greatest research being done is on acupuncture and traditional Chinese herbal medicine. These are whole fields. Yeah, I'll just keep tapping it. Whole fields of care that have their own educational systems and ways of thinking about health that may be different than conventional Western biomedical medicine. They all have to do in some way with manipulation, chiropractic. We may be more familiar with chiropractic or osteopathic manipulation. Craniosacral therapy is meant to be lighter or non-touch, but lighter touch. And massage therapy, again, I think more people are familiar with. A lot of research on infant massage therapy in neonatal units and improving feeding and growing. A lot less in child massage therapy. I think there's a perception sometimes about the implications of touch in children, and unfortunately we've come in our society to see touch as a negative. If you look about how children, and I'm not even talking about abuse circumstances, but in a hospital, when children are touched, it is usually a negative experience. They're having their blood drawn, they're having something done to them. And so wouldn't it be wonderful, and my colleague Tim Colbert talks about this, that if we could sort of help to reclaim touch in a hospital setting or in therapeutic settings as a positive thing, wouldn't that be a wonderful thing to do? And there certainly is reason to think that in terms of anxiety, stress response, many parents are worried about preparing kids for procedures, dental procedures, MRIs, EEGs, blood drawing, throat cultures, what we perceive as maybe simple things, or depending on your kids, maybe not, to prepare them in ways that help allay anxiety and fear. And what we do, even in as simple a setting as just my encounter with the child for the first time doing a physical exam, what I perceive, I think about the process a lot, but at times it's just what you do. You go through your day, you do your checkup, you listen to the lungs, the heart. We don't even think about it some of the times, but for these kids, and really for all kids it applies, this can be perceived as a major stress and can be traumatic. And so how we approach, I have in my space a lot of open room and windows and space, and so if for somebody, if the child's more comfortable sitting in my chair in my office, I don't care. It's fine. If they come for a well check and that girl that day does not want me to check her left ear, guess what? I don't have to check her left ear that day. You know, there are times, unfortunately, we have to do things we don't want to do and the child doesn't want to do, but when we can be flexible and say, you know what, if you can, if it's the kind of setup, next time you come in, we'll make sure we take a look at that. Trying to work and think about the process is important. I should also mention, with some of these therapies, massage, craniosacral therapy, therapeutic touch, and I'll get to Reiki and energy healing, these are therapies that are meant to be taught to the caregiver or the person themselves to do at home. So there's a shift that needs to happen where we help families provide in-home self-care. It's not so much that we need to be doing these things to them. We can train parents how to help themselves and how to help their kids, and it has a double benefit that way. So many of these therapies, part of it is teaching the parents how to do it. So when we do massage training in our center, my nurse Karen will do 2 workshops, 2 Saturdays with the parents. We'll train them how to do it with the child there, an infant or older child. Then they go home, and they can do it there. Homeopathy I breezed through only because it really is quite complicated. If you're not familiar with it, really the theory is that remedies are made by diluting natural substances. So it could be chamomile. You take chamomile herb and you dilute it, 1 in 10, 1 in 10, 1 in 10, 1 in 10, on and on, until you may have a 1 in a million dilution. And these are labeled 6C, 30C, 10C, about how many times we've diluted these 1 in 10, 1 in 10. And the theory is that the more dilute this substance is, the more powerful it is. That's the homeopathic theory. And that the substance, if you used in large doses, one of the therapies for sleep disorders is coffea cruda. You say, how does that make sense? If you drank a ton of coffee, you'd be up all night. The more dilute, the more powerful, and the more similar, the more likely it is to cause the opposite effect. So, I know that's hard to conceptualize, but it's being used more and more because it's perceived as less traumatic to the system. Some children cannot tolerate vitamins or herbs at all, and some parents will pursue homeopathy. Energy medicine, Reiki, other forms of non-touch, manipulating energetic fields. It's fascinating from a study of physics and energy, and I think someday it'd be great if we had some explanation. We may never. It may not make any sense to us in any systematic way, But that being said, this is something that people practice and will utilize. Children with autism may not tolerate touch, some of them, so this is more of a hands-off. And it may be just the process of relaxation that helps them. Yoga, I think, is wonderful for all kids that can do it. It's really been shown to be helpful in many conditions. What we find with autistic children is some do better when they're involved with family members, and again, it may be a way to encourage relationship. You don't have 20 kids at one time. It's very small groups, 2, 3, 4 at most typically. You need a lot of room. You want to be careful about what's in the room and not worried about it. But there are ways to adapt yoga, both in its physical forms and stretching and movement, and also in its meditative forms with breathing. And so it really is adaptable and can help with sleep and stress and anxiety, flexibility, fitness. So when we talk about this new paradigm, there's an interplay between all of the different factors I've talked about, from bench research to bedside to what we do in hospitals, what we do in our practices, what we do in our families. It is no longer okay to say we have a medical system that takes the patient, brings them in, treats their disease, and sends them on their way. That works well for acute care conditions, and I would not abandon that. If you need surgery on your leg for something, of course you're going to do that. And there are many things for which that is true. However, with children's health in particular, and autism as being one of the sort of beacons of concern for us today, whether it's autism, whether it's asthma, whether it's cancer, whether it's obesity, whether it's diabetes, whether it's high blood pressure, whether it's cancer, many of these disorders are rising at rates never been seen before. And these are the types of conditions kids have today that are presenting to us at home, at school, to therapists, to physicians. And we are challenged. We are challenged about how to address those needs. So I would offer to you this paradigm. We can call it integrative medicine. You can call it good medicine, as Kathy Kemper has. You can call it whatever you want. That's not the point. And I hope someday we get to the point, I don't need to stand up here and talk about a word, integrative medicine. It's really about a philosophy of care that, as I said, involves a whole child approach that is holistic, that reflects concern about genetics and what's happening in the body biologically with environmental factors, broadly defined, not just environmental toxins, which are important in the air we breathe and the water we drink and the food we eat, but also social environmental changes and their impact. And how we work together to meet these challenges, that is our opportunity that we have today. What we've seen, and on the plane I was reading an article by Sandra Steingraber. I don't know how many people are familiar with her work as an environmentalist. She is a cancer survivor and someone who's written about the impact of environmental conditions on children's health and adult health as well. And the paper was addressing economy and ecology, the two ecos. And she had a bet 20 years ago with one of her grad students, that her friends, which would collapse first, ecology or economy? One took one, she took ecology, he took economy. They're both a little right now. And she's sad about winning part of this bet. But the point she makes is that when you look at the economy, of which ecology and health is a crucial component, I don't think anyone would deny that, look at what's happened in our way we've addressed that. We have presidential speeches on primetime TV. We've got congressional groups meeting with people and having hearings. We've devoted billions of dollars in stimulus package. There is an urgent attention that's mobilized very quickly in these bailouts and discussions. The mainstream media, that's what they cover. The front page of every paper, every internet news source, every major media source, this is a crisis. What if we applied, and this is her idea, what if we applied the same approach to the environment, and to children's health. What if we had the president up and speaking about this, congressional people irate, up in arms, meetings on Capitol Hill happening every day? What if MSNBC and CNN and Fox News and all the local stations covered this in the same urgent way they cover the economy? And that is important, I'm not saying that. But what if we gave the same urgency and the same resources? Imagine what we could achieve. And so I think this is a crucial time. Our kids get it. My kids are 8 and 11. They understand in a way that I could never have understood at their age. Yes, I try to be a positive role model. I think that's part of it. I think it does start with us. But I look at them and I look at their classmates and I look at the kids today who are in their 20s and their 30s, the millennials, who are coming of age, who are going to be the single biggest voting bloc in this country very soon. And it gives me great hope that we can all work together, because these kids aren't going to wait for us to do it. They are doing it now, and we need to help them in ways. I know this, again, is focused on autism, and I think that there really is no more urgent public health matter than that. You've seen the statistics from your state. I know them in my state. I know them around the country and around the world. This is an urgent public health crisis. But it is also, when we think about an iceberg, I think we are seeing the tip of the iceberg. And these kids are the proverbial canaries in the coal mine. You know, they used to send in the canary to smell the fumes and see when the mine's going to collapse or when there's a problem with air quality. They were sacrificed. That's not right. We need to watch them. We need to pay attention. I don't have all the answers. The research that I presented today provides a lot more clues and theories than it does concrete answers, but I think these clues are worth following. And so again, I really would encourage all of you to go out after we finish, and we're going to have another great presentation, and we're going to have a terrific discussion. I think all of us welcome your comments and your questions to continue this dialogue. But go out there after you're done, take a minute to reflect on what we talked about today and have an intention to go forward, connect with one or two other people, and make this part of what you do. And I think for our kids, I think that's what they deserve. Thank you.
Hello, I'm Allison Golnick, and I am a pediatrician at the university here, and today I'm going to share with you a few studies that we've done recently at the university. It's my honor to follow Larry here, who does such a nice job defining things and really naming issues and addressing them head on, so a lot of my work is done for me, and I appreciate that. Let's see. I'd like you to imagine this scenario with me. This family is visiting their pediatrician, and the parent might be thinking, "It's so good to see Dr. Smith again. She's always so nice. But I'm not sure if I'm going to tell her all the treatments we are using for Patrick. I'm not sure if she'll even know about them, and I think she might judge me. We know that the treatments help Patrick, but I don't know if she'll believe me about this. I bought a multivitamin specifically for children with autism on the internet. I know it's good for Patrick, but it would be helpful to know if there are any potential side effects and what we should be looking for. Sometimes we feel like we've run out of options. What does modern medicine have to offer for our child anyways? I just want the best for Patrick." And the physician could be thinking, "Oh, here's Patrick and his lovely family again. He's making such great progress. They have so many interesting ideas, and they are using so many treatments. I have not even heard about some of them. I wonder about whether any of them could be dangerous for Patrick. I really want to be supportive of them, but I really don't know that much about what they're doing. The big challenge for me is that they want answers, and I don't know if I have that many." So these experiences are not unusual for physicians and parents, and might even be not that unusual for a lot of you out here that are other kinds of healthcare professionals. The key research question today that I'm going to be describing to you is, what are the attitudes and practices of physicians regarding complementary alternative medicine for children with autism? And the overarching goal of this research is really to bridge a gap that I've described here to you between parents of children with autism using CAM and physicians. So let me start right here and give you some definitions of what I'm talking about today. I'm going to be talking about primary care. So when I say primary care, I mean a physician and the medical team that really drives the child's care. Primary care is where a family first brings their concerns. They might even be the first concerns about autism, might be some concerns about sleep, but they first usually come to this person. And the primary care medical team provides long-term care so that they consistently come back to these people. This group may send them out and refer them out, but then they will come back to their primary care home. And also, the medical team is responsible for coordinating the majority of care. So this could be all sorts of different examples. Maybe a family practice doctor with a child who has asthma, or maybe even an oncologist with a child who has a cancer. And today when I say medical home, Larry touched on this, I mean primary medical care that is comprehensive, so it involves outside resources, and the physician and the team know about outside resources like social workers or appropriate therapists. The care is coordinated, so like I said, when the primary care home sends them out to see the neurologist, they come back and look at the recommendations together. And it's also family-centered, and that means that the physician and the team listens to the family and also clearly explains things, but even more, it really means that the family is involved in improving the care so that somehow the primary care team actively solicits inputs from the family and says, how do you think the care is going, and what do you think we should do to improve it, and then uses that input. And today when I say CAM, or complementary alternative medicine, I mean a group of diverse medical and healthcare systems, practices, and products that are not generally considered part of conventional medicine, but may be part of an integrative approach, as Larry's described for us. And when I say modality or CAM modality, that just means a method of treatment or therapy. So first I'm going to show you a study that we did here at the university. It was a national survey of parents. So we looked at parents nationally, and in the light blue represents the parents who reported that their child's primary care did not meet the goals that the medical home has set for them. And children with autism are on the left here. So you can see that children with autism are half as likely as children with other special health care needs, that's the acronym on the right there, to have medical homes. So what that really shows is that 3 out of 4 parents of children with autism reported that, no, my child does not have, and it was specifically comprehensive care, coordinated care, or family-centered care. So that's a lot of room for improvement for us. And we analyzed these differences. They remained despite adjusting for things like severity of the child's condition and insurance status. As far as background studies around CAM and autism, Larry's touched on quite a few. We know that from parent surveys, at least over half and maybe as high as 92% of families with children with autism, their children are being treated with these kinds of therapies. Larry also mentioned the survey that Greg Liptak did in 2006, which looked at families where families of children with autism were more likely than parents of children with other kinds of special health care needs to rate their physician's CAM knowledge as poor, and they wanted more information about this from their physicians. Susan Levy and Susan Hyman did a review in 2008 looking at the reasons for why families of children with autism used complementary alternative medicine. And they found that it really was not necessarily that they were dissatisfied with their conventional medicine, but more so that they desired multiple approaches or may have had concerns about side effects of traditional medicines, or maybe because of their personal health beliefs. So as far as physicians here on the right, we know from a lot of studies that physicians are interested in complementary alternative medicine, and they would like to get more education around this. What we don't know is we did not have any previous research on physicians asking them specifically about complementary alternative medicine for autism. So now I'm going to present to you a more recent survey that we did at the University of Minnesota. And this study asked physicians about their attitudes and practices around complementary alternative medicine. So we conducted a national physician survey, and the physicians were primary care providers, so we included family practice physicians and pediatricians. And we asked them about their attitudes and practices for children with autism spectrum disorders. And from here on, I'm going to say autism. And these were individuals from birth to 18, but I'm going to say children as well. And we asked them to compare their attitudes and practices for children with autism compared to these other groups, so children with other neurodevelopmental conditions. This might be things like cerebral palsy or mental retardation, and also to compare them to children with other kinds of chronic and complex issues, which might be like cystic fibrosis or diabetes. And these kind of comparison groups can give at least somewhat of a frame of reference for a survey-type research like this. So we first asked the pediatricians and the family practice doctors, when a patient comes into your office, do you ask them about complementary alternative medicine? And the physician responses were on a 1 to 7 scale to rate how often they ask their patients about this. The light blue bar here on the left demonstrates the responses regarding autism. So you can see here that physicians who responded said that when a patient with autism walks through my door, if they have autism, I am much more likely to ask them about whether they use complementary alternative medicine compared to a patient who walks through with cystic fibrosis. I also gave physicians a list of potential barriers to care, and this included multiple things. Things like reimbursement is challenging for me, or I do not have enough time to care for this patient. But physicians reported that frequent use of CAM was a greater barrier for them when they saw children with autism. This study did not go into the reasons why they would say that this was a barrier or a challenge to their care. I also asked physicians, are you interested in more complementary alternative medicine education? And again, they said, yes, we are. And in particular, we're specifically interested in learning about this for children with autism compared to these comparison groups. Next, I gave a list of recommendations of CAM modalities. So this list is fluid, as Larry showed, and this list was also dreamed up a few years ago, so it changes so quickly. I am going to now present to you, let's see, I asked physicians whether they encouraged the modality or whether they would accept it if a family was already using it, whether they would discourage it, or whether they were not knowledgeable enough to give a recommendation. So now I'm going to give you kind of the top view in each category here. So physicians most frequently reported encouraging multivitamins, and this study did not differentiate the dose of these, essential fatty acids, melatonin, and the study did not ask whether or not that was for sleep use, and probiotics, and again, the study did not differentiate whether that was for GI symptoms. So from these recommendations, we might say that physicians who responded to this survey are integrating some CAM modalities that may be supported by emerging evidence but need further research. Next, as far as what physicians were most likely to say that they would accept if a family is already using, were the gluten-free, casein-free diet, elimination of sugar, preservatives, and additives, or probiotics and essential fatty acids. Physicians were most likely to report that they would discourage delaying and not completing immunizations, chelation, anti-infectives, which is a really broad category, could include something like an antifungal or minocycline, delaying but completing immunizations, or secretin, which is a gastrointestinal medicine that was used in years past and extensively studied. So from this list, we could say, potentially, that physicians in this survey reported actively discouraging some forms of CAM that have been refuted by evidence or carry significant potential risks. And as far as physicians saying, I don't have enough knowledge around this to give a recommendation, these were secretin, B12, chelation, and melatonin. So next, we conducted logistic regression to explore the associations between physician characteristics and encouraging at least one of these forms of complementary alternative medicine that were on our list. So nearly 60% of the physicians who responded to this survey encouraged at least one of the forms of complementary alternative medicine on this list. So the light blue on the left bars represents those who encouraged at least one form of CAM modality from the list here. So you can see that physicians who desired more complementary alternative medicine training and said, I want to learn more, or I often ask my patients about CAM use, or I feel that I have better on this scale CAM knowledge, were also more likely to be the ones that would encourage complementary alternative medicine. This slide is about education, and the left column of pies here are physicians who reported that I have previous autism training. I have gained this in medical school residency and continuing medical education. And you can see that on the left here, the physicians who reported that they had autism education were also more likely to encourage at least one form of CAM. Now, this study didn't look at what was the content of this education, and it was self-reported, and we're not able to tell what the quality was of the education either. And on this slide, you can see that females on the left were more likely to encourage at least one form from our list. And on the right here, younger physicians were more likely. And in the middle here, physicians who reported they had a greater number of patient visits of children with autism over the past year were also more likely to encourage at least one form. We also asked physicians their recommendation around applied behavioral analysis. And the physicians who reported that they would encourage applied behavioral analysis were also associated with those that were more likely to encourage at least one form of CAM from the list that we gave them. So there are limitations to this preliminary descriptive study. The response rate was lower than desired, but I still think it's hard to get physicians or anyone to answer surveys in this day and age. Responder bias is always a potential in surveys, and it's important to think about this. One thought that comes to mind, I think, right away is it's plausible that people who are really interested in complementary alternative medicine got this in the mail and opened it up and were excited to put it back in the envelope and send it back. I did ask people to rate their CAM knowledge on a scale from 1 to 7, and the average score of respondents was 3.5, so right in the middle. But of course, I don't have anything to compare that to. And despite the fact that the sample size was actually 500, it still did not allow us to analyze the CAM modalities individually in groups, so it would have been nice to be able to break these into groups, something like those that have some evidence and those that have no evidence. But we were not able to do that with the power that we had. We even tried to do that. So a conclusion from this study here is that physicians desire CAM training specifically for children with autism. And they often inquire about CAM when they see a child with autism, at least compared to our comparison groups. They view CAM as a challenge for practice, and specific CAM modality recommendations varied. And physicians who encourage at least one form of CAM from our list also reported greater, we could say maybe autism experience and the number of visits that they had and reporting education. And they also reported greater CAM interest in that they always asked their patients about it or were more interested in learning about it or reported greater previous CAM knowledge. The following are thoughts on translating this research to practice. So physicians should ensure that patients are using effective therapies, which is likely to include a combination of intense behavioral treatment and school supports and social skills and communication supports. And it's also important for the physicians to ask all patients who come through their door about CAM use, in particular children with autism, because of the high prevalence of use. Physicians should use a framework to evaluate CAM therapies that their patients are using for safety and efficacy. And this is really a reason why events like today are so important for us all to come together and talk about these and start working on getting a frame to evaluate these things in. And we can work together to improve models of care. When we make improvements in healthcare infrastructure overall, then those changes can really spread to all providers. And examples of this might be reimbursement. They might be also providing providers tools for families to help them choose target behaviors and measure them over time. And models should really involve families in quality improvement, so really actively solicit feedback from families to then incorporate into the care models that we have. And I believe families should really lead this effort. Families can help to make medical care practical and more effective for them in their homes. And families know their children the best. So, thank you.
Thanks to both of our presenters. Now we're going to do something a little different that I had mentioned before. We are going to have a panel discussion with our two presenters and two other distinguished guests, Dr. Nimi Singh and Dr. David Wallinga. And I think Nimi and David will introduce themselves and say a little bit about who they are, since you haven't met them yet. And then at that point, the floor will be open for questions and discussions, and I think it's a rare opportunity to have such outstanding experts here ready to talk to us about wherever our interests take them. For those of you who are here in the audience, there will be two folks wandering around the aisles with microphones. So please be sure you get a microphone before you ask a question. Otherwise, people in Greater Minnesota won't be able to hear you. And for those of you who are in Greater Minnesota, please email your questions to us at cmhdata@umn.edu, and the same microphone bearers will read your questions to the panel. So, Dr. Singh?
Good afternoon. Good morning. I'm Nimi Singh. I'm Division Head of Adolescent Health and Medicine in the Department of Pediatrics here at the university. And I was asked to participate in this panel, I think, for a couple of reasons. One, I've had the recent privilege of being invited to participate in the creation of a more comprehensive model of care for children with autism, to be based in our Autism Center here in the Department of Pediatrics, where we want to use a care coordinator model and really provide the community with the first point of contact with someone who is going to be able to guide patients and families as they either discover that their child may be exhibiting signs of autism, or these may be families who already have been told that their child has the diagnosis, has had recent care or has years of care and want a second opinion. Families who are identifying other physical complaints or behavioral complaints that aren't being addressed yet with their children, who want help with navigating the medical system. Families who are having difficulty or need to negotiate the social services arena. And the other piece of it is we're really hoping to then be able to provide a team approach that include experts in developmental and behavioral peds, in the psychological care of these children, in being able to help community primary care providers create a medical home for their patients out in the different communities across Minnesota, and then a small subset of families who may actually want to have their primary care housed at the University of Minnesota with either Dr. Golnick or myself. So the other piece of it is my area of focus prior to looking at autism is working with adolescents around mental health promotion. And that's really another focus of mine in terms of clinical work, education, and research. And I think that's all.
Great. I'm David Wallinga. I'm a physician by training and education. I graduated from the medical school here, but for the last 15 years or so, I've been a full-time advocate for children and environmental health. And the perspective that I carry is in some ways a historical perspective that this conversation really builds on. And I would trace it to the early 1990s when really there began to be a initially small but growing movement of people that were looking at the literature around pollutants and seeing a lot of evidence that they were having impacts on children's health beyond just lead. And there was a landmark study from the National Academies of Science in 1993 called pesticides in the diets of infants and children. And it wasn't just about pesticides, but really it was about why child development and developing organs like the brain, the immune system, and the whole process of development really left children more vulnerable to these pollutant exposures, oftentimes than adults. And I moved back to Minnesota in 2000, around the same time that a group of physicians, most of whom were affiliated with Physicians for Social Responsibility, but then also including myself, put together a book called In Harm's Way. And what we were trying to do is to say, you know, there's actually quite a bit of science out there in various places around the impacts of environment on learning and developmental disabilities, not just autism, but other learning and developmental disabilities as well. But it's in silos. And frankly, we don't read outside our fields, and so people aren't seeing the whole picture. So we undertook a synthesis piece, and then it was really on a shoestring, and then subsequently developed a pediatric environmental health toolkit for clinicians to use to explain some of these concepts to their patients and to use in their practices. And now that is a free online tool that the CDC has on their website as of about 2 months ago for CME credit. And so this has been a long and ongoing conversation. I now work for a nonprofit think tank in Minneapolis called the Institute for Agriculture and Trade Policy. So for the last 5 years, I've really been building on the idea that food is a really important part of the child environment, that it's not food and the environment, but the environment encompassing everything from us to our food and specifically how it's produced. And so we've put together a number of consumer guides around food topics and why a consumer might want to choose food and produced in this way rather than that way, or food without artificial food dyes, for instance. And I think a lot of that's relevant to what Dr. Rosen was talking about. So just to sum up, my approach is an ecological approach to children's health, where a number of the factors beyond genetics are important potential co-contributors to various health problems, including learning and developmental disabilities, but also important potential exacerbators once those conditions have formed. And that's the way we come at these things.
We're open for questions. We have someone up here.
So I have a question for Dr. Wallinga. Mm-hmm. Do you have any conversation as part of your nonprofit with the school lunch programs in the state?
We do actually. There is an effort funded by the W.K. Kellogg Foundation to work with the people that determine school lunch programs in several cities across the country, and St. Paul is one of them. And we have a local foods program director, Joanne Birkenkamp, who's working with the St. Paul School District and around that program.
Good morning. I have a couple questions. One is when a family, I'm a nurse, first off, and when a family says that they've had tests for whether or not they're gluten sensitive or not, and the test comes back negative, what would you recommend to that family in terms of diet modulation? And is that test accurate in all cases or not?
Can you all hear me? Yeah. Well, the first question I would want to know is, what was the test? You know.
Could you please use the microphone? I'm sorry.
It varies in situations. Oops.
Yeah.
It varies, but simple blood test as well as scopic exam.
So, answering that question, I would say there is no test commercially available, to my knowledge, that accurately predicts success of a GF-CF diet or any diet. We use tools, we use lab tests, and I think there's a tendency among some practitioners to use a lot of lab tests. And labs can be a guide, but they really don't predict, and that's one area that's hotly debated. So what I would say is, that's interesting, let's look at that. I think, acknowledge that the test was done, look at it. Specifically, if it's a standard food allergy test, it bears looking at. But I would say, look, what is your interest in the diet? What do you hope to achieve by it? What are the reasons why you would think about doing that? Talk about that, and if they are interested, to support them, make sure nutritionally that the child's doing as best they can, and have clear goals and measures to say, how are we going to know if this is successful for your child? My personal opinion is there's really no lab way to guide that currently. So I don't know if anyone disagrees.
So my question about that is, in a sense, you're helping the family to form their own N of 1 experiment. Is that accurate?
Yes.
Could you say a little bit more about that, about what kind of instruction you might give to a family about how to assess the impact of an intervention they're trying?
Sure. So it's a concept, we are used to in research looking, the gold standard being randomized controlled trials of many kids where there's one intervention that we look at across a wide population. We look for a sample size to see that it makes sense. With interventions, specifically with conditions that are so individualized, where the response is individualized, you can do what are called N of 1 studies. And technically what that means is there is an intervention. It can be a gluten-free, casein-free diet for their child with autism. And you want to try to remove as many biases as you can, which to try to blind it. Now that's very difficult to do, and in practice, that's not what I do most of the time. So I want to distinguish. In a research setting, you could devise a trial for each individual subject where you put them on gluten and off gluten, and on gluten and off gluten, using really medical foods. You would not have, you would have difficulty, you wouldn't be able to want to tell what it is, and have measurable outcomes in terms of, have the family help define the outcomes. What is it? Is it sleep? Is it focus? Is it stims? What is it? Language? Whatever the things they want to improve. Is it stomach symptoms like constipation or diarrhea? Have these clear outcomes. So in practice, the way this works for me is we still help them define individual outcomes. We can't blind the therapy, but we do have them try to have a succinct time period to try this intervention without any other biomedical intervention. It is naive to think there's going to be no other change in their environment during this period. That's impossible. You're not asking them to stop ABA or to stop going to school or to stop new interventions. And to be frank, many families continue to integrate other biomedical interventions at the same time. So these are very difficult from a research perspective, but I think the point is we're trying to work one-on-one with each child to have definable outcomes and measurements so that we learn what is success and what is not. And sometimes that's going on the diet and back off the diet and back on the diet to see what the differences are.
I might add a little caveat to that, that I agree with all that. And I think, thinking about an issue like this, children are so individual. So it's important, to even look at the kind of flip side, if you will, to that, which is I have families come in to me and say, we really did that diet and we did it for 6 months and we did not see behavioral changes. And I can say to them, with the evidence we have right now, we cannot tell you that across the board for all children who have been diagnosed with autism spectrum disorders, this has been shown to have behavioral improvements at all. And like Larry said, if there's a potential for this having some use, likely, as we know with autism, it's more likely to be in a subset. So I think it's important to also think about, the family input and the potential guilt around something like this, and also reassure them from the evidence from that approach. And there have been some studies done on the gluten-free, casein-free diet, but a lot of them have methodological weaknesses, and that's a very challenging study to do. Susan Levy in New York is coming out soon with some data on a larger study, but we don't know what that'll show. And I know she had a lot of challenges to also doing this study, so we should be getting some more data in the next few months, but we don't know what that will show.
We have a question in the back here.
Good morning. I had a question for Dr. Golnick. I was surprised to see how many physicians referred out for ABA as a CAM, and I was just curious, were you surprised to see that? And what do you think, did they have knowledge of it and that's why they referred out to it? Or what do you think that high referral level for that was?
And forgive me if I'm not following your question exactly. The actual asking them about whether or not they would recommend ABA, you know, I've got to get the percentage exact. I think it was around even 50 or 60%. Now, I did not say intensive behavioral intervention. I said applied behavioral analysis. It might have been better to say something like intense behavioral therapy. So potentially a general family practice physician was not familiar with that term, applied behavioral analysis. It certainly speaks to the fact that we need greater education around autism and effective therapies. Absolutely. I also asked physicians about what I called their competency, but it was a whole mix of things that they said. I have the capacity to care for these kids. I have the resources. And physicians who were more likely to encourage applied behavioral analysis also were the ones who reported that they had a higher self-competency. So that certainly fit together well in the study. I did not present that today to say that, you know, that all makes sense in a picture that some people are feeling more that like they have a greater capacity to care for these children. But I think probably in general the biggest message for that is physician education.
I am wondering, and any of you can answer this, if you recommend organic food to the family that has a child with autism, and then also perhaps to the typically developing child, and perhaps even then to a pregnant mother who is carrying a fetus. Would you recommend organic food?
I think that's me. And I can't tell who's asking the question, so I don't know who I'm looking at. Can you raise your hand? Oh, in the back. I think it's worth thinking about how the food is raised, whether it's certified organic or not. And for those of you who don't know, the USDA now has a specific set of criteria around what is considered organic with third-party certification. That means somebody's gone out to the farm and checked to make sure that that's what the farmer's actually doing. So some reasons to think about a certified food product like organic. What does that mean? Well, for meat production, like chicken production, certified production means that they're not adding organic arsenic to the chicken feed, which is something that is done for most other chicken produced in the country. So I have a lot of concerns about organic arsenic being put in chicken feed. We know a lot about arsenic in various forms. Inorganic arsenic's a known carcinogen, so yeah, it's definitely toxic. And some forms of arsenic now have been identified as hormone disruptors. So if you're concerned about that, then yeah, that might be a good criteria. Organic meat also is not raised with antibiotics added to the feed, which, like arsenic, are really just used to make them grow faster. In terms of plants, and I think probably all of you know this, organic production means no synthetic pesticides derived from petroleum or natural gas. And most produce items raised conventionally, that is with pesticides, have pesticide residues on them, at least one and often more than one different pesticides. And for example, a food product like peaches, the average peach raised conventionally could have 6 to 8 different pesticide residues on it. So for the dirty dozen, so-called dirty dozen, the top 12 produce items that tend to have the most pesticide residues, it might very well be a good thing to buy them organic. Now, you could also buy them from Farmer John down the road or through a CSA and have a pretty good idea of what practices that farmer's using, and that might be a less expensive way to go and get the same sort of result that you're looking for.
Just wanted to make a comment on that too, because someone asked me during the break, if you were, has anyone ever studied, and I think the answer is no, an organic casein diet versus a non-organic casein? Is the problem the casein? Is it that it's non-organic? I think it's a fascinating question, and I think it leads to, what advice we give parents in general. And you asked about pregnant women, very important. I think in an ideal world, we would want to provide food sources that were as locally grown, as non-toxic as possible. I think we all agree that's the ideal. It is tough in the real world in terms of affordability and accessibility. And while there are not and may never be clear health studies where I ate this food and the next week I was better, that's very hard to do. I think intuitively we know that by removing additives to foods, and those are pesticides and organics are important, but it's also high fructose corn syrup and trans fats and all the food dyes and additives. I thought it was nice that physicians were tolerating their patients not having additives in their foods. They should be actively encouraging that. So these are messages that we do seek to provide, but I think we do have to be mindful of the societal limitations on that advice. I think that's tough.
One other quick note. There's actually 30 years worth of studies looking at something called the dilution effect. And this is the phenomena that conventional production, by selecting for yield. In other words, I'm a farmer, I'm going to institute practices that give me more of what I'm growing rather than focusing on other things like nutrient density. That if you look across a wide range of different produce products dating back decades, that there's been a decrement in the nutrient density for things like vitamin C and some of the antioxidants and some of the other nutrients too. So buying food raised organically or under more sustainable models may actually give you a nutrient boost when you're providing nutritional support to these kids.
I think we have a question in the front.
It's actually a follow-up question. When you are trying to, how do you track the success of an intervention? When you talk about the N of 1 study, do you have a tool that you use to track that so that it's not just parent input? I mean, I'm a parent of 5 kids, and middle son has autism. And I know how difficult it is to track some of these things. And sometimes I think I'm really on the mark in terms of, how often he stooled in the last 2 weeks. And unless I write it down, I don't know for sure. So what tool do you use with families?
That's a good question. Do you want me to start with that? So that's an area that there are a number of people around the country who have developed or are developing sort of outcome measure tools. I'll tell you what I do, and then I'll tell you what else is available. So I don't use a standardized measure because I don't think it's flexible enough for primary care practice and for most busy families. So what I try to do as part of, we have, just like we do in education, we have goal-setting meetings and conferences. And I sit down with the parents and say, look, I'm going to track and you're going to track, and we're going to make a list of the top 3, 4, 5 things you want to see improvements with this intervention or these interventions. And what I would love for you to do is, I know you're busy each day, just write a little note, brief little note, today, X, Y, Z. And when I talk with you and when I evaluate your child, I'm going to do the same thing over time. Obviously, you're going to have many more endpoints than I'm going to have. And we're going to sit down, or we're going to talk, or we're going to email, or whatever it takes to do. This is where coordination comes in and accessibility comes in. And we're going to track that over days, weeks, months. Some of these interventions take longer than a few days to see an impact. But you're right. You look back and say, 2 months ago, what did I do? I don't know. Maybe it made a difference. So it is important, and we do these goal-setting conferences and follow-ups. There are some checklist items that have been developed, like the Autism Research Institute, the DAN people, have a parent rating form. And what they do is they actually publish aggregate data. About X% of parents said this intervention was effective for my child. It's interesting. Not particularly scientific, but interesting. And so they have a checklist you could print out and use. It's pretty complicated, I think, and I don't know if anyone uses it, but some practitioners do.
I'm going to make one more comment, too. I appreciate the question. The questioner is even working with me, and my team is here today. I'm in primary care, and so we're working on how do we make that something that's easy to use in a 15 or hopefully 30-minute visit together. And so we really use, right now, a basic calendar that we're working on. How's it easiest to choose your target behaviors together as a team and then monitor those? We give them a rating scale. But I did want to make one comment that I think that it's really important for medical practitioners to team up with more of the behavioralist providers. They do a really excellent job of this. And I had such a great discussion with one of the behavioral providers in town here last week where they actually have a completely separate section where they coach families in terms of how do I think about the changes I'm going to make and how do I measure them over time. So it's really even separate from the therapy. And I think that behavioral therapy providers do a great job of this. So this is an area where we could really team up with them to say, okay, if we're going to try one of these interventions or a medicine or anything, let's see how you guys do it and use that.
Just another kind of follow-up question to that. Are they always, when you're looking for data points, are they typically behavioral data points, or do we do, a lab data point, in addition to that? Or do we use a pain predictor? I mean, do you have sort of a same set of sequences for?
It depends. Because it's so individual, I would say it includes, yes. The answer is yes, all of those. For some children, it is digestive markers, how often they go to the bathroom. For some, it's pain-related. For some, it's how many ticks or stims they have in a given hour or day. For some, it's seizures. For some, it is language or communication or understanding. For some, it is behaviors or opposite. I mean, you can define it in any of those ways. It would be nice if over time we could look at some of those markers that are below the surface and have more objective data. I will pick up on what Allison said, which is when you look at Jill James' work, the stuff I presented about B12 and folic acid, what I love that she's starting to do is partner with Doreen Granpichet, who's a behaviorist, with a CARD program to have, and these are extensive behavioral observations, but in research settings and academic settings, it would be wonderful to have that kind of data.
This is a question from Outstate Minnesota, from Long Prairie. Has any work been done with kombucha or kombucha, spelled Kombucha, a Chinese or Russian elixir that cleanses toxins or pollutants from the liver and intestines?
That's a good question. Yeah, kombucha is a fermented drink, if you will. Tea. It's a tea. It's from a green. I know they can't hear you, but it's really a fermented food, like a tea source. It's made as a tea, an infusion, which is purported to have high antioxidant levels, probiotic levels. So while it's one of these sort of functional foods that's pretty hot right now, the answer is no. There's no research that I'm aware of.
Hi, I have a question for Dr. Rosen. I am also a parent of a child with autism, and I don't want to get too personal and too detailed, but he's 10 years old, and his main issues are attention, social difficulties, and withdrawal. So there is no real gastrointestinal issue, except for a peanut allergy. So my question is integrative medicine something that you would recommend, even though there's no real GI problem there? Or does the GI piece have to be kind of like a starting point? Mm-hmm. And the second part of my question is, we are currently considering attention medications, mm-hmm. So I want to know if the two things exclude each other, the attention medication and the integrative medicine.
Great.
Thanks.
Great. No, thank you for bringing that up and for sharing your story. What you are struggling with is what many, many, many parents struggle with. And when we talk about integrative approaches, the point is we do look at blending those, and it's to take the first point about gastrointestinal disorders. There's no study that shows that you need to have problems, observable problems with the GI tract, meaning things that you would see. to have success with some of these interventions. Perhaps your child is one of those who is in a different group who has more focus issues. And so there are interventions that have been looked at to help with focus and support. There are some, when they look at children in the attention deficit literature and in the autism literature, there have been implications with iron and zinc and other micronutrient deficiencies. Thyroid function is certainly something people will look at. There's also a therapy called neurofeedback, which is a form of biofeedback that has been studied in children with ADHD and higher functioning children with autism who have attentional issues. It involves meeting with a therapist once a week and doing a variety of mapping electrical activity and perhaps modulating that using computers. And it's found to be, in some studies, equally as effective as medication over a long period of time. So there are things that are worthwhile exploring, omega-3 fatty acids being one, and again, looking at diet and nutrition as a support for brain function. Additionally, you asked about medications. One is not, you don't need to do one or the other, and that's really the point of integrative medicine. Is I do have children in my practice who I use both. And I guess our hope is, I have very few parents who come in and say, today's the day I want to start medicine. And I understand it's a bias with the kind of practice that I have, but even with many of my colleagues, that's not usually the parent's first choice. So it's important to explore complementary approaches. However, sometimes that is the best answer for that child, and there are ways to integrate. So, does that help? Yeah.
Do we have more Greater Minnesota questions? I see you carrying around a couple of. Can we do the Greater Minnesota question?
This is a question from Crookston. If these biomedical treatments are effective, why are so many of these organizations, DAN, ARA, IFM, listed on Quack Watch as being questionable?
You want to take that one? You can go ahead.
Dr. Jeffrey Bland, who is a nutritional biochemist whose ability to pull together basic science and clinical research is probably incomparable of any of the sort of educators out in the public field, is also on Quack Watch. And his science is grounded in basic cell biology, molecular biology, genetics, anatomy and physiology. That is the same science that biomedically trained practitioners studied in school, only he has connected the dots in a completely different way. And what I would say is it's very uncomfortable to be asked to take on, again, to use the terminology that Dr. Rosen brought up, to be asked to take on a paradigm shift when there's a philosophical approach that's really the mainstay of a particular discipline, and then there's a group of questioning practitioners or scientists who say, let's start from a different point. That feels very uncomfortable. And if I could summarize the difference between the two philosophical approaches, traditional Western biomedicine starts with disease developing and then observing the signs and symptoms and determining whether or not somebody meets full criteria for a disease, at which point then we move forward with drugs or surgery, typically. And if patients do not meet full criteria for that disease, we often do not have very much to offer. And yet, there's clearly, it's sort of again, that iceberg approach of we function only at the level, the traditional Western biomedical practitioners function at the level where things are manifest, but we're not very well trained or asked to think about what are the precursors, what are the physiologic imbalances that preceded full-blown disease, and are there ways in which we can identify that through signs and symptoms or even laboratory studies such that we can step in and intervene prior to that process being left to go its natural course and then turn into full-blown disease. And that is the focus of one of the organizations that Dr. Rosen brought up was this Institute of Functional Medicine. And the reason why they use the term functional medicine is because they really talk about how if you go back to understanding how the body functions at a basic level to maintain balance, and then understand what are the kinds of factors that cause the body to go out of balance, and what is required in order to help it return to that balance. Are there environmental toxins or exposures that are interfering with normal enzyme processes, for example? Are there nutritional deficiencies that are not allowing the cells to do everything that it needs to do? And that is not the way traditional medical schools teach physicians to think about what's going on in the lives of their patients and families. And we know that there's a deficit there. There's tremendous gain in the Western biomedical approach for many diseases, and we made incredible strides in so many areas. But the subset that we're talking about who are left frustrated are the ones who go to their doctors and say, I have fatigue, or I have concentration problems, or I have aches and pains, and the conventional laboratory studies come back negative. And then the patient's told there's nothing wrong with you. And yet the patient knows something is out of balance that wasn't there, say, 6 months prior. And the concern is, how do we, in a responsible and scientifically grounded way, still stay with the patient and meet them where they are and try to explore with them ways in which to try to restore balance in their body, even though what's going on with them isn't labeled as a full-blown disease in a textbook. So those are the folks who choose to take that on end up on Quack Watch. Now, that's not to say that there aren't folks out there who are doing seriously questionable things and are involved in treatment modalities that are that have been shown to do harm. And that's critical for us to be vigilant about that. So again, goes back to Dr. Rosen and Dr. Golna's slide of that grid where you really have to look at safety and efficacy and make sure that you're not doing harm. But to even be willing to meet families where they are when they don't meet full criteria for disease can sometimes make you suspect within the traditional biomedical field, because that's not what we were traditionally taught to take on, and yet that is the growing bulk of symptomatology that's really emerging in the population, this sort of increasing prevalence in chronic illness. And sometimes people meet full-blown criteria, sometimes they don't, and yet I personally, as a practicing clinician, don't feel comfortable saying to a family, I know you're suffering, but I didn't learn about your disease, so I can't help you. I need to understand better as a clinician, and I want to work with them and explore what is available and what might support their system in a responsible and scientifically grounded way to the best of my ability.
I would just, that was very eloquent. And without, without defending any one group or practitioner, I would say I would encourage the questioner and those who have similar questions to read about the history of alternative medicine. There are various guides around there, and understand the socio-political climate in which those questions are raised and those observations are made, in which wholesale professions, which may have to do more with economic or socio-political considerations, are defined as quackery. So you have to think about that in its full context.
Acupuncture was considered quackery 40 years ago. It's the mainstay in many orthopedic clinics. It's being recognized in many areas of medicine. Actually, biofeedback used to be considered quackery, and it is very much recognized as one of the more effective treatments for migraine headaches, for chronic pain syndromes. And so again, some of it is just a matter of the research having to happen, and it depends on where we are in the timeline of history. So,
And I just want to refer to a conversation that I know that you and I have had previously that I think the N of 1 study concept is really critical to, which is that autism is not a single disease entity. It's a whole collection of causes. And so it's difficult to say ahead of time, this will or this will not work for a particular child.
I think Dr. Goldnick and Dr. Rosen, I'm here, both referred to studies, but I'm interested in how much information there is about what parents are using and whether, if you have any good references or sources or want to give a little more information about what alternative means parents are using, how much information there is about that, and their responses about it. And also, if you could add, what's a good history of alternative medicine?
Sure. I mean, right off the start, my mind goes right to the parent surveys that we both referenced there. The parent surveys that say that over 50% of children are being treated, and I'm certainly happy to share all those resources with you. It would take a long time to tell you all the exact names, and those go through, kind of, and it's all parent response surveys and some convenient samples. That means people who just came into their clinics, but anyways, it goes over the reasons why and other things like thinking about, it was in one study, parents who had a higher level of education and I think maybe even were older were the ones who are more likely to be using those. So, it goes over demographic factors of what might be associated with it. Other than that, do you have any specific, internet? Yeah. Sure. And I think I have some of them down, and Larry has some of them down in the handout that you have there, but I'd be very happy to share all that information.
There are, I'm trying to look it up right now because I can't remember the author's name, but you can always email me and I can send you. There are two particularly very good histories of alternative medicine in the United States, which go through sort of discipline by discipline and trace, it's very illustrative. As far as what parents are doing, that was something we looked at in our survey that I presented with the 92% use. We looked at what the different things were. Some CAM surveys will talk about global terms, about this is in our study, what the parents were using. There is a database, again, on the Autism Research Institute website, ARI, where they compile parent-reported efficacy. But it's a list of all the different therapies. So, and it doesn't necessarily say how many are doing each one, but that is one other resource.
And we can save you the trouble of getting all of our emails. We'll post the relevant links and documents on our website.
That's great.
I have two questions for Dr. Walenga, and they're both practical and one is very short. What was the website where we could find the toolkit for pediatric environmental health?
I believe it's also the CME course is at the CDC, ATSDR component of the CDC, but the toolkit itself is at www.igc.org/PSR. And I think that'll also give you a linkage to the specific CDC website.
Thank you. My other question is a practical one also. I work with families who don't have much money, and I'm interested if you could list for us the best bang for your buck in terms of organic, which would be fruits and vegetables that have the least pesticide loads, and the ones that have the most nutrient-rich loads.
Well, I think the best bang for your buck isn't necessarily organic. It's to buy in season, either at the farmer's market or through a farm share, and then freeze. Like, I go to a U-Pick'em organic berry farm up near Forest Lake, and then just freeze boatloads of strawberries, blueberries, raspberries, etc. And my goal this year is to learn how to can and do some of the other things, because I actually do think that's quite economical. If you are going to pick organic and you want to shop at a supermarket, if you look at our website and look for the Smart Produce Guide, we have a whole series of these consumer-oriented fact sheets called the Smart Guides. So we have a Smart Guide to meat and dairy products, a Smart Guide for produce, a Smart Plastics Guide, and those are all at iatp.org.
I have to put in a plug, I'm sorry, for David's website.
IATP.
The Institute for Agriculture and Trade Policy. It's a wonderful, wonderful website for any of you who are interested in understanding better the environmental health issues. And more importantly, it's not just about raising your fear about, oh my gosh, we've created such a mess. They really have wonderful practical guidelines and things that you can do, things you can do to change your own home environment, things that you can advocate for. I was just speaking with a couple. We were concerned about the possibility of solvent exposure in the schools, and what can we do about that? And this website allows you to really take it from the individual level to the family, to the community, to the advocacy level. You can go as far as you want, and I just really commend David and his colleagues for the work they've done, because it's all there. So I for any of you who are interested, I really invite you to check out the website.
Thank you.
I have a question concerning diagnostic tools used with autism, and in particular, I'm interested in PET scans, positron emission tomography, and also MRI. Where do those two fit in the diagnostic framework?
They're both still considered experimental in research settings. No one is using those in any regular fashion diagnostically. I think, there's certainly a great interest in developing those kinds of tools for early diagnosis and recognition, and also in terms of subtyping. If we can say this type of brain leads to this type of function, and how can we intervene? I don't know if you're familiar with Daniel Amen's work in PET scanning. He is a physician who's looked at PET scan patterns in ADHD and trying to subtype ADHD. And he writes about integrative therapies with nutrition, et cetera, but his interest is mostly in diagnosis. It is not currently recommended that all children with autism receive an MRI. It's only under certain circumstances. But I think, as we go along and understanding more about the links between anatomy, physiology, and behavior, I think you may see more of that.
Hi, I'm a psychologist here at the U, and I wanted to make a comment, an observation that we see from time to time, and then get your take on how to advise families in those situations. We see families who have been advised to go on a list of complementary alternative vitamins or supplements, and they have the sense that it's working, or the child is slightly better, but meanwhile they're paying $500 a month, for this long list of interventions. How would you advise a family like that?
Well, I really like what Dr. Rosen said, was we really have to think of nutritional supplementation as not lifelong but temporary, and at the same time really trying to maximize nutrition through whole foods. And so Robin, I hear you. I mean, and the other piece that Allison brought up was families being reluctant to not spend that money because then they feel guilty that they're withholding something that might be of benefit. And that's where, again, who's to say that it wouldn't be worth doing a trial off all of that for a month? After the child has been on it for a really long time, for example, and track if there are any significant shifts. So again, I think we're in the practice of healthcare for clinicians. We're very reluctant once we've started something to remove it, even when we're not convinced of its efficacy. I mean, we do this with antihypertensive medication for adults. We do this for typically for psychotropic medications for mood disorders. Once it's been started, we're reluctant to stop, even if it's not clear that it's really had benefit. And I think we have to do more of that and allow, again, the family to track whether or not there are differences.
Would you advise starting one by one as well? Because, I mean, they have 10 different ones, and maybe it's one that seems to be making a small difference and the rest
It would depend again. So much of it would be depend on the story, the symptoms, what we think the main physiologic imbalances are. So omega-3 fatty acids are an example of a nutritional supplement that is being written widely as being supportive in a number of chronic inflammatory conditions, and it's because it supports the functioning of the cell membrane. Now, your body's made up entirely of cells. They all have cell membranes. It improves receptor function. It's hard to argue that that wouldn't be of benefit for many people with illness, and probably a bunch of us without overt illness. But some other supplements, it may be more questionable. So again, I doubt there's a one answer approach depending on what the situation is, but I completely agree with you. I think to some degree it may be unconscionable to not address the $500 a month issue.
Well, here's the challenge: is that we want to see, and we do see, the substitution. People say, "Oh, great, I don't want to use medications, but I'd like to use something more natural." So there's a pill-for-pill substitution, if you will. It's just something you get as a prescription and something you get at GNC, your vitamin shop. You know, I think that within nutritional work or integrative work, it's a different concept than the one pill, one disease model. So many of these therapies are synergistic and meant to be used together. On the other hand, what I've observed, and it's taken me years to observe this, in the first few years I didn't, but now that I have families for over 10 years that I've seen with young children, first diagnosed, later on, there's patterns that develop. They're really gung-ho. They do everything they can. They spend a ton of money. And over time, they tend to burn out. And they tend to stop spending so much money. And now look, some of the times it's because they don't see results with their kids. Sometimes children do improve in ways and they recognize, I don't need all these things. And so I do spend a lot of time working with them to peel back in a way that acknowledges anxiety and guilt and all of those things. So,
can I share a visual metaphor that I heard yesterday that I think really gets at this core issue of something of a clash between different paradigms for thinking about these issues? The speaker yesterday said, thinking of the child as a whole system, a child with sort of a patent system that's working well is like a river contained behind a dike made up of a lot of smaller sandbags. And with some of these kids, maybe what we're looking at is a total dike collapse, and all these sandbags are strewn around. And the conventional medical paradigm might say, let's find the one sandbag that we can put back to recreate that dike. And I think what you just said in a different way was, we found that we need several sandbags, and they actually work together to create that dike. So it's almost the wrong question to say, which sandbag should we pick? I just find that to be a really effective metaphor.
And another piece of that is there a way to transition towards a more whole foods approach that will support and allow decrease of some of the supplements, if not all of them?
Right.
So again, it's like getting back to sort of what we evolved to take in as humans to the best of our ability.
Unfortunately, I'm afraid we've run out of time for today. I want to thank you, the panelists, for a wonderful discussion and our presenters. And I want to thank the audience, both here and Greater Minnesota. Please be sure to fill out your evaluation forms, either here on paper or online for Greater Minnesota. And again, thank you very much for what I think has been an outstanding series this year.
I've got a bunny. Thank our speaker.